connected by purpose, driven by passion. Welcome to the Spark Live webinar series, where we gather to curate, convene, and showcase excellence and innovation from across the child and youth healthcare community. Our goal is to spark conversation, ideas, and action. Children's Healthcare Canada would like to thank our funding partners for their ongoing contributions that support all of our programs and activities. Keep up to date on all of Children's Healthcare Canada's webinars, events, and announcements. Sign up for our Spark News e-bulletin by visiting our website at childhealthcan.ca and follow @childhealthcan on Instagram, X, and LinkedIn. Now, on to today's webinar.
Well, good morning, everybody. Bonjour à tous. Welcome to another edition of Children's Healthcare Canada's Spark Live webinar series. Je m'appelle Marjolaine Provost. My name is Marjolaine Provost, and I will be your host for the next hour. Before we dive in, we would like to begin by acknowledging that Children's Healthcare Canada operates on the traditional and unceded territory of the Algonquin Anishinaabe peoples. We recognize and deeply appreciate their historic connection to Ottawa. Today, Ottawa is home to many Indigenous peoples from across Turtle Island. Santé des Enfants Canada s'engage à établir de nouvelles relations et à approfondir celles qui existent déjà avec les Premières Nations, les Inuits et les Métis. Nous sommes reconnaissants de pouvoir partager cette terre alors que nous travaillons à améliorer de manière tangible la santé et les soins de santé des enfants d'un océan à l'autre au Canada. So today we are delighted to have our colleagues from the BC Children's Hospital Research Institute, 3 doctors, starting with Dr. Hal Seiden, Stephanie Glegg, and Sharon Ho, who will be presenting on easing pain and advancing care, a new pathway for children with severe neurological impairments. The Child Bright Pain Pathway team will share how they developed the pain pathway, which is a systematic clinical tool designed to support clinicians in assessing and managing pain while improving care for families. Children's Healthcare Canada is pleased to support Child Bright through our Spark Impact KMB Knowledge Mobilization Service. As well, Children's Healthcare Canada hosts a number of networks, including the Pediatric Pain Management Practice and Policy Network, which we co-lead with Solutions for Kids in Pain, SKIP for short. Network membership is open to all those interested in the topic and affiliated with CHC members as physicians, employees, or researchers. For more information about the Pain Network, please visit CHC's website or look at the link that was just put in the chat. To join the network, you can complete a survey or see the chat box again for a direct link. So we will start with Dr. Hal Seiden. Dr. Seiden is a clinical professor at the University of British Columbia and an investigator at BC Children's Hospital Research Institute. He is a specialist in pediatric palliative care, and his clinical and research interests include pediatric pain, complex care, and palliative medicine. He is also a passionate educator and advocate and continues to shape the future of pediatric palliative care through compassionate clinical work and innovative research. Next up, we have Dr. Stephanie Glegg, who is an assistant professor at the University of BC and an investigator at BC Children's Hospital Research Institute. Dr. Glegg is an implementation specialist who studies the most effective ways to move knowledge into action to improve health services delivery, and health systems. Her work supports pediatric and adult populations and spans individual, organizational, community, and policy contexts. And last but not least, we have Dr. Sharon Ho, who is also an assistant professor at Simon Fraser University and a psychologist and investigator at BC Children's Hospital Research Institute. Her clinical and research interests focus on diversity and health equity in child health and wellness, with a particular attention to the role of culture in shaping health outcomes. Dr. Ho's work aimed to inform the creation and delivery of culturally responsive interventions to underserved and underrepresented communities of children and families. Welcome, everybody. It's now my pleasure to pass the mic to Dr. Seiden.
Thank you, Marjolaine, and thank you, Logan. I think we can have the first slide up if Sharon, you can do that. Thanks. So good morning, everybody. We're going to be talking about pain in children with severe neurologic impairment. And the fundamental problem here is that these children are often expressing pain-like behaviors. They're crying, they're tearful, they may be frowning, they're certainly maybe thrashing their arms and legs. And we don't know why it's happening. And it can be going on chronically for some of these children, and it's very frustrating for families and for clinicians. And so many years ago, going back to 2010 or so, we began to tackle this problem. How do we understand this better? So in this webinar today, which I hope you will really get a lot out of, we're going to do three things. We're going to talk about how we developed this pathway to understand pain for these children. We are then going to move from our very first phase study where we really tested the pathway to saying, how does one actually implement this into practice? And I think this is a key element. There's so many projects that come up with results, but don't go into the next step about how to get it actually into the coal face where families and clinicians are. And then talk about what we've done in terms of patient-oriented research to build long-term partnerships with the families. Next slide, please. So I've already mentioned this thing, children who can't tell us where it hurts. And, you know, for some children, this is because they're just very young. I mean, this has been a problem in neonatology for years. But we're seeing this problem in children with neurologic impairment who have many, many reasons to be crying and to be expressing these kinds of pain-like behaviors, as I call them. And one of the things that we recognized early on is we don't know how much of this is pain, that there's actual tissue injury, versus the child is somehow irritable for another reason. And it might be discomfort, it might be emotional, it might just be that they are feeling irritable. And one of the analogies I often use is if you saw a toddler crying, screaming, thrashing, but they were in the grocery store, you might say they're having a tantrum. If they're getting an immunization, you might say, oh, the child's having a pain experience. So we said, well, this is either pain or this other thing we call irritability, and we don't know why it's there. How do we assess this? How do we determine and start to divide out and make it a little easier to understand what's going on? We called it the pain pathway. So here I'm going to talk about our very first two studies. Next slide, please. This is the typical evaluation of the nonverbal child with pain and irritability. I'm not going to make the animations work, but you can see that the child goes, you know, to the gastroenterology, the GI service. They go to orthopedics, they go to neurology. They have appointment after appointment after appointment. And each time someone does another history and physical, asks questions, orders blood work repeatedly, orders urine repeatedly. And in a 2010 study that we had, we found that the average family was followed by 7 different clinical teams for their child's pain. I'm not talking about individual physicians. I'm talking about teams who followed the child around pain. And the range was from 6 to 14 teams. So we really began to say, well, what's going on here? This is a complete mess. And that's where the pathway came. Next slide, please. To understand how do we, thank you, Sharon, to understand how do we do a much more rational, simple approach to this? And furthermore, how do we divide out what pain is caused by tissue injury, as we call it, nociceptive inflammatory pain, from this other thing that's a little harder to understand, but at least we know we're not in a treatable space, which is this irritability, neuroirritability, now called sometimes nociplastic pain. There's all kinds of terms for this. The nice thing about standard, what I'm going to call nociceptive inflammatory tissue injury pain, the twisted ankle, the broken arm, the reflux disease, is once you know what it is, there's a treatment for it. Maybe the hip is out of joint, you can send them to orthopedic surgery, there's a repair for that. If it's reflux disease, there's treatments for that, and so on. So if you could do something simple to say, okay, it's not that box of nociception inflammatory pain or tissue injury pain, I can deal with that. How do I deal with the other things? And we haven't gotten to that other thing yet. This is very stepwise and in some ways painstaking research. In respect of where these children are at, we decided we were going to do a health services study comparing our pathway against standard care. And we were going to apply a randomized controlled trial, which is very infrequently done in this population. Again, there's an equity issue here about the size of studies, the kinds of studies we do in children. And we said we're going to do an RCT, which is a very bulky thing to do. We chose to do this just before there was a pandemic, and we all know how that came out. So some of what you're going to see here is the results of trying to do a study in the midst of the pandemic. The other thing we did with this study is not only did we do it as our RCT, so the highest level of evidence, we did it at 4 centers across Canada. You can see it listed there. And my colleagues at those centers were terrific in participating in the study. And I'm very grateful to them for all their work. Go back one more slide, Sharon. Yeah, thanks. So what we did is we enrolled every child at baseline, and then we randomized them. And of course, you need a control. We put people on what's called a wait list arm. You can see that, which means we didn't have a placebo, but people were just on wait list for a while, for about 10 weeks, or actually 8 weeks in this case. And then the pathway started right away. And then the children on the wait list cross over and receive the same care. Okay, next slide, please. So these are the participants. We had less than the number we wanted for power. We were looking for about 120 children. As I mentioned, the pandemic really disrupted that. And about not quite even males and females. And most families were living with someone who helped them with their care of their child. Of course, as you see on the far left, study after study after study have a high preponderance of mothers participating in these studies. And we ended up with 72 children, which is enough to give us some reasonable data. Next slide, please. So the big reveal here is that the pain pathway per se, when we see them at baseline on the left, that's when we first meet the child, they all have a fairly high pain score, as you can see. And after the time of crossover, so remember, crossover has been occurring, that the children who have been on the pathway have been receiving the intervention, which is really this very intensive kind of evaluation. Let's rule out things that we know are causing pain. And we said, well, does it change the pain score? And of course, it may not change the pain score. It's really designed to find pain, but we hoped it would have changed the pain score. We'd find things identifiable. And the greenish group, turquoise group, is the pathway group where the controls, and there's no difference in actual pain scores. Next slide, please. However, what we did find, we followed these children out for up to 6 months because it can take a while for everything to work its way through. You can see that over time, the children, and remember, everybody at the last time point will have been exposed to the intervention, so it doesn't really matter which arm they were on. But we went from relatively high pain scores, the red, those come down, fewer children have high pain scores, and more children have low pain scores. So over time with the intervention, and it may just not have been the right time duration for it to have worked at the crossover, we're seeing that there is improvement in pain as we're starting to reveal these tissue injury or nociceptive inflammatory types of pain. Next slide, please. So what are the big outcomes? Well, 33, about half of the kids, we did not get that identified a pain source, which isn't a particular surprise because not all those kids with irritability and pain have tissue injury type pain. We did find about 8 kids where we really were able to identify, hey, this is a specific problem. Maybe there's a seating and wheelchair problem. Maybe it's the scoliosis. Maybe it's the reflux disease, a poorly positioned gastrostomy tube, dental caries and abscesses, you name it. That's the green group. What's really interesting is the resolution in the 16 for whom there wasn't an identified cause, but the pain gets better. And this is over a long period and should have accounted for the variability. And we have some theories about why that may have occurred that we're going to be testing in the next phase study, which Sharon will be talking about. Let's see the next slide, please. So this again just really replicates what I said before. A certain number of these kids did not ever get through the pathway. Again, there's a problem in terms of COVID. I think the other problem, you'll see it on the later slide, is waitlist was a problem for families. Would I have chosen the same design again? Probably not. So for those of you who are methodologists, I've now learned by going with a purist methodologist about RCTs that they probably aren't as good for big health services trials as we had hoped. Next slide, please. As you can see, this is what you'd expect from this kind of study, and this is a vulnerable population of children. And you see that 2 of the children on the study had died in between. We know that this is a highly fragile population. The loss to follow-up and COVID disruption are obviously the things that you're going to expect given what was going on then, as well as just the nature of RCTs in general. Next slide, please. So As I pointed out at the primary comparison point, the outcome showed no difference, but I'm not as worried about that because 30% of the children, 1 out of 3, got some benefit from being in the study in terms of pain, either identified as a cause that we could treat or fully resolved for other reasons. And we also know that the pain goes down over time, which is really the same way of saying that. One of my colleagues, I.L. Cohen, who some of you know at Sick Kids, and he's on the study, teased me a long time ago. He said, "You're just doing an RCT of common sense." And I said, well, if it's so common, why didn't anybody ever follow this? And I think that's true. There is a common sense approach. I think one of the things I'm very proud of the participation of the families and of the many staff who did this study, but I'm also pleased that we've done this, I think, in respect, as I say, of this population in a very cautious, thorough, and stepwise way to really try to get some information out that would be of benefit to them. And I think that might be my last slide, Sharon. Is that correct? Yes. So I will turn it over to Stephanie.
You have. So this work was carried out in pediatric health centers, hospitals, 4 different ones across Canada. And our next phase, which is funded by ChildBright, is to roll this out into the community, because we know the kids live all different areas across our provinces and territories. And here in BC, Children's Hospital is in Vancouver, so quite a distance for folks to travel. And kids are accessing pediatrician care in their home communities. So our phase 2 is pre-post hybrid implementation effectiveness study using implementation science. And what that means is that we're studying the effect, the intervention, the pain pathway, as well as studying the process and outcomes of our implementation strategies. So multi-methods, we use a patient-oriented approach. So family partners engaged throughout the process. And what implementation science is the study of the best ways to move knowledge into action to improve healthcare. And we're interested in the factors and mechanisms and processes that are required for successful adoption of the pain pathway here. This slide shows an overview of the study. I won't go into all of the detail. I'll speak a little bit about the frameworks on a subsequent slide. But our implementation strategy to support adoption of the pain pathway is based on our barrier facilitator assessment, which Sharon will discuss, using primarily education, training, and modeling for clinicians to help them understand and adopt the pathway. We evaluate the process of implementation. So how many physicians did we reach? To what extent is the pathway adopted? Did we do what we said we would do in terms of implementing? How feasible is it in the community setting? And is the pathway sustained over time? We're also interested in the cost of implementing, and as well as the cost for families who are attending the appointments to go through the pathway, because it does take repeat visits for them to uncover the sources. And then in terms of implementation outcomes, we're looking at physician behavior change, meaning are they adopting the pathway, changes in knowledge, skills, confidence, and attitudes towards the pathway, and their satisfaction with the implementation strategy, so that can inform scale up to other settings. And on the intervention arm, we're looking at identifying or resolving pain and irritability, as well as family well-being. So this is the NIRN, or National Implementation Research Network, active implementation frameworks. So we're using this as a process framework. There are basically 4 steps. The first is exploration. So we work with community pediatricians to explore their interest in engaging with the pathway, and identify barriers and facilitators to using it. The installation phase is where we set up everything required to implement, which includes the education, training, resource development, looking at workflows, etc. Initial implementation is when we launch the pathway. In some cases, we might implement part of the pathway or implement it with a certain number of sites, and then full implementation, we expand that to be all components of the pathway or additional sites. as well as looking at sustainability over time. So stage one, here we are exploring, so establishing relationships with people with lived experience, the families, but also we have a clinician panel that helps advise on our course of work. We co-developed our study protocol with lived experience partners and gathered feedback from phase one participants and team members, and then moved on to surveying and interviewing community pediatricians as part of our barrier and facilitator assessment. This helps us inform what we're doing in our installation phase. And so, as I mentioned, our implementation plan includes education to address a lack of knowledge about the pain pathway, training to address limited skills in some areas that were identified, and modeling to help support confidence in carrying out the pathway. We designed this. We're developing the materials so that we can implement them as part of our strategy. Our initial implementation involves gathering data to evaluate use of the pain pathway in community pediatric practices. We plan to use audit and feedback and expert consultation, and iteratively update the implementation plan based on emerging barriers, facilitators, as well as learning across sites. So what's working well in certain practices, can we adopt that and transfer it to other sites to improve the experiences of the pediatricians and families and improve the likelihood of success. And then at full implementation, we expand to more community practices. Part of the intervention is nurse coordination support, which perhaps Sharon can expand on if needed, to see what is it about the nurse coordination support that is helpful, looking at cost effectiveness as well, and how can that be replicated in different clinical settings. And then looking at how things went and identifying ways that we can support the sustainability of the pain pathway use over time. And part of that sustainability is looking to see if we can implement local champions that can support other pediatricians in their communities, reducing the reliance on our study team moving forward, because we won't be doing this study forever. And then our theoretical frameworks here for the barrier facilitator assessment, we're using the theoretical domains framework. This is a determinants framework. It helps us to categorize the barriers and facilitators of implementation, and there are 14 domains that are listed there. It helps us look more comprehensively at what might be hindering or supporting uptake. And then the behavior change wheel helps us to identify priority mechanisms of action. So this means, what is our change theory? How do we think that these implementation strategies are going to work to target these barriers and facilitators in order to achieve the implementation outcomes that we have? So we also use evidence from the literature about what strategies are effective for which populations in which settings to help us select the implementation strategies. So that's a background on our approach, and I'm going to hand it over to Sharon, who will share about our barrier facilitator assessment and what we found so far.
Thanks, Stephanie. So, as Stephanie pointed out, one of the first steps we wanted to take in preparing for this implementation, bringing the pain pathway from the hospital into the community practice, is to really understand from the community pediatricians that we want to engage with what would be some of those anticipated roadblocks to implementing the pain pathway in their practice, but what would also be some supports or helpful resources we can offer to help them have success in this process. And so to kind of set out on finding this information, this past year, our team has conducted
interviews and surveys with pediatricians across the province. So over this time, we spoke to 12 community pediatricians that are kind of across the province, generally well represented, including kind of more northern areas of the province, as well as on Vancouver Island. And so what we did is we asked them to complete an online survey to provide us with some information about their professional experiences and kind of the landscape of their clinics and practice experience. And then we also engaged in an interview with them online. The goal here was to gather that information about their past experiences, insights on their general sense of what it's like to learn and engage with using new clinical pathways being introduced, and more importantly, how do we partner with them to kind of offer this tool and ease them into using this when they're seeing children with severe neurological impairments in their practice and in the families that they see. This was highlighted kind of throughout Hal and Stephanie's parts of the presentation, but what's been really important for us is engaging with people with lived expertise in this research. What has been unique that we brought into phase 2 is that we invited the clinicians or pediatricians that were in phase 1 RCT who had experience using the pain pathway, as well as those who had experience practicing in the community to join a clinician advisory panel to offer us insights into what's feasible and what can help with our implementation process. And in addition to that, a really key component is we invited the families that previously participated in the RCT to kind of offer us that input about their own experience participating in the pain pathway and how we can think about using and learning from their insights into building our implementation plan. And in addition to that process, what's been really incredibly helpful and valuable is that we do have 2 family partners that bring lived experience caring for children with health complexity who have been longstanding members of the core research team, even long before the study even came to be. And so kind of as a whole, we work really collectively as a team. And I know Stephanie highlighted some of that process, which is that we co-design the study protocol, we co-develop the research questions, and we engage in a very much equitable process of collecting the data and recruiting participants and approaching the data analysis. And I'm happy to speak to more of this and answer any question about process, because I think for us as a team, we've reflected on how this has been so valuable to what's helping us build this study plan. So of the pediatricians we spoke to, this is really a snapshot of understanding their background and context. The information we were really trying to gather is to understand the context of their practice and how bringing in a tool like the pain pathway could inform the way that they engage in care for children with health complexity and those that present with pain and irritability. So what we know, for instance, is that many of these pediatricians wear multiple hats, right? Some of them might work in exclusively in the community context, but others also work both in the community as well as in a hospital context, which meant that for different practitioners, they're going to have different access to resources, connections, and networks. Over half of the participants of these pediatricians practiced in areas that were over 50 kilometers away from the tertiary pediatric care. These are important information that we want to gather as we think about access to care and what it means to support them in offering this kind of pain management for children with severe neurological impairments. And perhaps most important, something that we learned from these interviews and the surveys is that over 83% of these participants talked about that they do see kids with severe neurological impairments in their practice. And of that, more than half of that proportion we're seeing those that present with pain and irritability. And so it's telling us that there is a need for us to offer some support in what it looks like to support the pain management for these children, and how do we support the community pediatricians in doing that. So analysis of this data, we're still kind of, I would say, like fine-tuning kind of the final messages we're giving, but we wanted to share some of the recurring ideas that came up for us. What we are seeing and what we're learning from the pediatricians that's important is the need for change in these broad areas of kind of pediatrician support. So for instance, pediatricians talked about the need for support in their skills development. And what that meant was more in the case of how do we find supports to help them build the skill set and confidence in managing pain and irritability for children with, severe neurological impairment. Specifically, the participants had expressed a desire for more consistent and standardized practice and guidance, which we really do believe the pain pathway can offer that kind of process and contribution. Participants also talked about, when it comes to learning and using clinical pathways, what they want is something simple, something visually organized, something that's easy to navigate for them, because these are the types of things that can really sustain their attention and inform ease in their clinical decision making. And so we really keep that in mind as we're trying to build our implementation plan. And last of all, I kind of tapped into this earlier, talking about, thinking about where they're situated across the province, where they're located across in distance to hospitals, the importance of the environmental context. So participants really spoke to the importance of, the opportunities for networking and consulting with experts in the field that they felt can really promote a more consistent engagement with a new clinical tool they're being exposed to. And more importantly, they talked about the importance of breaking down the silo of being in community practice, and perhaps offering a tool like this with the supports asked could be an opportunity to kind of be more engaged and connected as a community of people that care for children with health complexity. To offer some context into what we're seeing as priority areas, I'll offer kind of highlight a few examples. Pediatricians talked about a tendency to be overloaded with information. So there are many clinical pathways out there. How do we offer opportunities for them to learn and access the pain pathway in a way that's readily accessible and available to them? Pediatricians also talked about what we know is quite common in their experience, that they're really at capacity and time is precious and limited. So if we were to offer them this tool to use in their practice, how do we coordinate that so that it's efficient, timely, and also, can ease the burden of their current kind of capacity and caseload? What has been very inspiring to hear is hearing about the pediatricians talk about the importance of involving family. They really spoke about how they learn from the families and caregivers, and that it's been kind of a collaboration in care for children, for these children with health complexities. So an example of a quote we wanted to bring in of a participant speaking to this is someone that said, "I see my role, as a community pediatrician, that I'm going to shepherd you through this and be your quarterback and hold your hand and help you and help you find the joy in parenting as we manage the medical pieces of your child's journey." Care journey. So we felt that this has really resonated with us in finding this opportunity in this research process to partner among researchers, community pediatricians, and families to offer this support for the kids who are presenting with pain and irritability. So what's next? So what we've offered so far really is this foundation in looking at how we came to develop and test the pain pathway and what it means to move the pathway from the hospital into the community context. And the first step we've taken to gather kind of this insight from those who could be involved in the implementation to tell us what can inform the success of this process. And so what comes next is to take everything we've learned so far to inform the development and refinement of our implementation plan, and to really prepare for those next steps of partnering with community pediatricians across the province, so that we can offer this tool and offer the supports needed to address those challenges that can come up when they're thinking about using the pain pathway and managing pain for children with severe neurological impairments. Because this is a study that's very much work in progress, we invite you to follow us along. So we do have a resource at the paindetectives.org, which will be offered here, that will allow you to learn more about the study as it develops and ways that you can stay involved with us, because we do invite that collaboration with people that bring that lived expertise or the interest in meaning and engaging with this work. So I'll offer a little summary on behalf of our team, just thinking about what we're trying to bring to you. And really, there are, I think, three main messages we want to offer, which is just to introduce you to the pain pathway, its origins, and why we think that having a research-informed approach to manage PIUO for children with severe neurological impairments, as Hal pointed out, a common sense approach could be of value to clinicians and families. We also really wanted to highlight the process of taking a theory-driven approach using implementation science to guide our research process. There is this value to gathering data along the way to inform what can bring success to creating change from research to practice, so that we can take those lessons learned or insights and data gathered to inform future implementations, because we certainly have ideas for how we want to bring this forward and at larger scales beyond this study. And finally, something that our team values and continues to learn so much about is integrating people's lived expertise. And for us, that's been to work with the families that we work with, for those that have children with health complexity, but also the clinicians that bring experience in this realm, and as researchers and clinician scientists doing this work in child health. And so with that, we just want to take the opportunity also to acknowledge and thank all the people that's been involved with this project. These are some of those people that have been involved over these years, but certainly not everyone. So we want to thank all of those that have contributed to this work, as well as our funders and other collaborators and supporters that have been involved in this work. And that will be the end of our presentation. Thank you so much for listening, and we're happy to take any questions at this time.
Perfect. I will turn my camera back on. Thank you so much, Hal, Stephanie, and Sharon. Thank you for sharing this innovative and important work. We have a number of questions that have come in. So our first one, is there a plan to make the toolkit available for families to help them recognize symptoms that may be a sign of pain in their child, specifically for those children that are nonverbal? And that question came from Stephanie.
I think that the plan is that the toolkit is of most value to the clinician, and part of the problem is that the, as I said, the manifestations of pain, all that stuff that a child does when there's some version of tissue injury, looks so much like what the child's just doing when they're upset, when they're irritable, when they're frustrated, when they're hungry, when they're bored. And I have a brand new postdoctoral fellow whose project will be to understand how do we actually evaluate those context pieces separate from tissue injury. So she'll be looking at home environment. She'll be looking at the child's context. She'll be looking at the factors. She's an occupational therapist. And so for her lens, and that may lead us later to a tool that will say, this is that thing that looks more like irritability, emotional space, frustration, and this is the thing that looks like tissue injury. The tool that we're presenting today is a more efficient and effective way for a physician to get within really 1 or 2 clinic visits back into, okay, I know that this is tissue injury or nociceptive inflammatory pain. We can deal with that. And there still may be elements of the other going on. So that's, yeah, I guess eventually, yes, but our very first steps are the ones that you've seen here.
Thank you.
I would say, I'm just going to answer one more thing, which is I think for the parent, I think the best thing is very close observation. You're with that child all day, and to think not just, why is my child screaming because something must hurt, but are the other things going on around them? What else is happening? So that's a tool that you can just use at home. Again, it's a common sense approach. Sorry, go on, Marjolaine.
No, thank you. So the second question, how can this research again be used to help family advocates for support in their child's pain care when their concerns about pain are possibly being dismissed or, not heard properly by healthcare providers?
I don't know, Stephanie or Sharon, do you want to tackle that one?
I think one thing I'll say is that in working with the family partners we have on this project, we talked about how important that is to address this question of how do we do this together? How can by offering the pain pathway into the community, how can there be a point of collaboration? And so what that could look like more so, I think, is helping families understand, like, here's what we're learning could be a possible approach to managing pain. Would you be open to trying that with us, kind of going on this process? And so I think we think more of that, and we hear that from the community pediatricians as well. So I think it has been input from both ends of wanting that, the opportunity to do the implementation project together, really as a chance to learn together, and to be a part of that process together. So I think that's one way we've thought about how to make this and offer this as a point of interaction and engagement.
And add to that too, one really effective way to share like for knowledge mobilization is family driven. And so if families are aware that this pathway exists, it's newly being rolled out into community. So checking out paindetectives.org to learn more about it and bringing that forward to your pediatrician and saying, hey, there's these resources I found out about, they might be helpful in figuring out what's going on with my child. And that, encourages the pediatrician to say, oh, I should look at this. Maybe there's value here. Maybe I can get some guidance, because it is very complex for these kids. So you bringing that forward is a tool for the pediatricians.
Thank you. Next question. What would you say are some of the most common misconceptions that parents or caregivers can have about children's pain? I know we touched a little bit on the, whether a tantrum in the supermarket looks exactly like an actual injury response. So I think that might be one, but what else would you add to that?
I think that it probably is the number one, and families kind of, and clinicians as well, sort of chase around pain as if it's all due to this injury. So the average family doctor, pediatrician gets overwhelmed and says, well, I'll send them off to gastroenterology, they'll solve it. Who then says, well, maybe neurology solves it. So everybody's trying to look at the organ piece without stepping back and saying, what's driving this behavior? And where are the sources? And that's what we're doing here with this thing, and saying, you can really efficiently, effectively get to the bottom of, a very simple example is part of the pathway piece is that everybody should have a urinalysis, both for a UTI, a urinary tract infection, which can be painful, and for stones, which these kids are more susceptible to. So that's just a simple example of, I should start with that kind of thing. Another example is the blood work. There's guidelines that ask you to get buckets and buckets of blood. And I look at that guideline and I think there's nothing in there that causes pain. No one's ever in pain because they're anemic, for example. But there are certain kinds of things that in blood work that would be of help. And so the pathway makes that more efficient. So I'd say that the number one thing for a parent is to think not all pain is a single kind of pain. There are multiple sources at the biological level. We talk about neuropathic, nociceptive, inflammatory, nociplastic. And then that's even separate from children whose brains are disordered and have this propensity to irritability. And that's separate from, I'm a very frustrated child. And I have one child who comes into our hospice, was here for days at a time, multiple visits, always cried. And his mother said, he never cries at home. And it took us a long time to figure out he was just homesick. So the nurses and doctors were all looking for pain sources. And the mom says, he just wants to be at home. And this was a kid who was coming in for respite. But it's a great example of the parent observation, the common sense approach. And we all had blinders on because we were all looking for pain. So I'd say that that's the first misconception. And I think the other is that families need to know that yes, it's good to go to the specialist, but why is the pediatrician thinking that's the thing to do? And how do you bring it back to your primary pediatrician and say, let's stick with all the basic things. We've been to the neurologist. That's not the answer. Why do you think it's the next step is orthopedics or whatever? So.
Anything else to add on that, Stephanie or Sharon? Okay, thank you. Then what are there, age-appropriate ways to help children communicate or describe their pain more effectively, or at least in a way that adults will understand?
Is that over to me again, I guess? So the space we're talking about are primarily nonverbal children. They're children with either primary brain disorders, brain injury, metabolic diseases, etc. Some children with autism spectrum disorders who are not able to communicate effectively. I'd say the best tools out there, there's something, and I'll put in the chat in a second, the non-communicating children's pain checklist developed by Lynbro in Nova Scotia many years ago, and the pediatric spelled English way pediatric pain profile by Anne Hunt out of Oxford. These are two different tools designed for nonverbal children. They're checklists that the families fill out, and if you bring that to your clinician and say, these are the pain patterns, those would be very, very helpful ways to start. The PPB looks pretty overwhelming online, but actually it's very simple. And I'd say that those are the two tools that will help you at least begin to tease out and describe for non-communicating children where their pain is. Once a child's verbal, they can say, my elbow hurts, I have an owie here, I fell off the swing set, whatever. It's that nonverbal period where you're trying to get to where is the owie. And Skip, by the way, Children's Healthcare Canada and Skip will have a lot of great resources around age-appropriate developmental ways of talking to kids who are neurotypical. So I'm going to put the name of, yes, I'm putting them in the chat right now. So before we
Thank you. We always love resources. Thank you for that. I've got 2 or 3 more questions here, and I think we still have time. So good. So how, this is a bit broader. How can schools or educators support children who experience chronic pain while learning? Sharon or Steph, maybe you want to give Hal a break and answer one of these questions.
I'll let Stephanie add kind of to what I'm thinking about, but I know this has been a point of conversation in our implementation planning. Is, you know, at what stage or down the line, the opportunities to expand what it means to offer this pain pathway tool, or like the way that we're educating people about what it means to understand pain and irritability, and using tools such as the pain pathway for supporting these children. So that, I think, you know, an indirect way of answering that is those would be where there could be opportunities to expand the scope of who we reach out to, such as engaging with schools and educators. But I don't know, Stephanie, if you have other thoughts on that.
Yeah, I'm just going to put my occupational therapy hat on. So parents are the experts of their kids, right? Ask the parents what works. Built into their IEP maybe are things like positioning breaks. If they're using wheelchairs, do they have a tilt and space chair, or do they need a break out of the chair to relieve pressure or reposition? You know, understanding what the source of the pain is very helpful in helping educators understand how to support them. But if we don't know that yet, then we need to observe and watch what cues the kids are giving us, and speak to the family about what strategies they use at home, compare what's happening at home to the school environment, just as Hal was describing in the other institutional type settings, to help figure out, is this pain or not?
Okay, that's great. Thank you. So I think we're actually going to wrap up right now. So again, thank you so much, Hal, Stephanie, and Sharon, for sharing your time, your expertise, your knowledge with us today. Merci encore à vous d'avoir été là aujourd'hui. Thank you for all the audience members who took the time to join us. We know how busy you are. We hope that this was informative and that you walked away with some practical resources that you can use today if you need. You can follow up by email. Thank you, Sharon, for adding that note. And I will just quickly go through our upcoming Spark Live webinars. So the next one is on December 10th. That one is called From Insight to Impact: Strengthening Services for Indigenous Children and Families in Canada's Children's Hospital, with Patricia Lee and Amy Shawanda. And a week later, December 17th, we are having a second one, Child Maltreatment in Young Children, Evidence and Insights, with Matt Caruana and Rita Jane. A little plug for our last podcast, which came out earlier in October, The Power of Pediatric Palliative Care, Equity, Access, and Hope. You can find our Spark podcast on all your favorite platforms. And last but not least, I hope you may have seen our Thrive report, Thrive, the Economic Case for Investing in Children's Health, which was the first of its kind economic analysis on the return on investment, specifically for children's health. I don't have to tell you that it is a good policy to invest in children, as it, we can reap the benefits up to fivefold on those investments, both in social and economic benefits. There's lots of documentation, the full report, all on our website. We encourage you to check it out. And again, just a last reminder, we are having our upcoming annual conference in 2026 from May 31st to June 2nd in the beautiful city of Calgary. So whether you're presenting or attending, we look forward to seeing you there. And it's always great to be with a passionate group such as this one. So again, a big thank you to our presenters, to our funders as well, and obviously to everybody who took the time to be with us today. So thanks and have a great day, everybody.